Hello, we are going to start this session with the keynote lectures of Mijna Hadders-Algra. I'm very happy to co-chair this session with Bernard Dan. My name is Alain Châtelain. Bernard Dan is now the chair of our scientific committee, and you can see how influential a scientific leader can be, because we are all forced now to wear bow ties. So I hope this will suit him. Okay. Maybe you can see that I'm not a scientist, but a parent, because although learning for 2 days how to knot a bow tie according to accepted methodology, I'm satisfied with it, although it's a mess. So, our foundation is now a bit more than 15 years old, and we are supporting high-quality research in Europe. Cooperation between people with CP, parents, and researchers is built in our genome. And I want to urge all of you to reach out to each other. What I mean is parents in this room should reach out to scientists here. They have to share their experience. They have to learn about methodology. I think it's important that we parents learn at work. And I think there can't be anything more meaningful if participation is the goal, according to the ICF, that professionals reach out to people with the condition and their family for their goals. So I want to urge you also to communicate. It is so important that awareness about children with disability. We are involved with children with cerebral palsy and adults as well, but you have also a role in reaching out to politicians and to help raise funds, because research is our future. So thank you very much to EACD. I'm very honored to hand some kind of souvenir to Professor Mijna Hadders-Algra in remembrance of this lecture, and I will leave Bernard introduce the topic. Thank you very much.
Many of us know Mijna, and the people who thought they didn't know her actually know her, because she's been so influential in the field. I first met Professor Mijna Hadders-Algra back in 1996 at a meeting on general movements during, what shall I say, the early days of a new way of looking at movements of little babies. Now, Mijna is a professor of neurodevelopmental neurology at the University of Groningen in the Netherlands. She has been very, very active within the EACD. She was secretary of the EACD when I first joined the General Management Committee. It was at the meeting she organized in Groningen that I learned that I could be the president of the meeting to be organized in Brussels. And she has inspired also and mentored many, many people in research, and many people in the room have been directly or indirectly have benefited from her novel ideas. Now, her latest achievement is a book which is published by McKee's Press on the SINDA, on Standardized Infant Neurodevelopmental Assessment. I think it's an important achievement. And Mijna was chosen by the scientific committee of la Fondation Paralysie Cérébrale because of her special attention and specific perspective on the very early development of children. And we're all very happy to have you as La Fondation Paralysie Cérébrale Lecturer for 2022, Mijna.
Thank you very much, Alain. Bernard, for your very kind words, the appreciation, and this token of appreciation. Actually, I don't know exactly what to say, but I think I've been given talents, and I simply like to share my talents together with colleagues around and being supported by a wonderful husband and friends. And so science, you never do it alone. And I think it's just our task to help the families and the children. So today, I was invited to talk about early intervention in at-risk infants. So what are we talking about? We are talking at children at high risk, biologically high risk, of a neurodevelopmental disorder. And this is the framework of the ICF-CY, you all know it. And these children have their initial problem at the level of the body function and structure. They have an impairment. But gradually, we really realized what matters most is not whether or not you have an impairment, but whether you are able to to be active and to participate in daily life. And that is one of the reasons that in early intervention, the family is really essential, crucial, because the family covers all the aspects. So in early intervention, really the family is central. And why is that? Because it's the family who needs to cope with the situation of having a child with special needs. It's the family that knows best what matters in their own life. And it's also the family who understands the child best. And like I mentioned, we really gradually realized that the most important outcomes of early intervention are home and community participation of both child and family. So those of you who've heard me before have seen this slide. And we focus on the right-hand side, the diagram that summarizes the neurodevelopmental processes occurring in the human brain. And you see a list of processes, and I won't discuss the details, don't be afraid. And so at the bottom line, you see the age, first in weeks prenatally, and so the bold vertical line is term age, and then age continues in months and then in years post-term. And you have to read the slide as such. When the line, the horizontal line is bold, it means that the process mentioned is super active. And when the line is broken, the process continues, but less abundantly. And now we know that the events occurring in the children with a neurodevelopmental disability occur very early. We nowadays also know that the average age at a diagnosis of CP is around 12 months corrected age, but with a huge variation. In some children, you can already diagnose it at 3 months, but in other children, it takes 4 to 5 years. But anyway, it means that we have a gap between the event that resulted in the neurodevelopmental disorder and the diagnosis. But this gap does not mean that we can't do anything. Of course we can. So we try to detect the infants at high risk, and so we can start the intervention in a period of life that the brain really is still developing strongly, so we have neuroplasticity. I will focus today on what we know about the effect of early intervention when the children are no longer in the hospital at the neonatal intensive care unit, so when they have come home. And like I mentioned already, it's really the family first. And in children who have been at the neonatal intensive care unit, usually multiple health professionals are taking care of child and family. And then we have discussions. Should we call these teams inter- or transdisciplinary teams? I would say it doesn't matter at all, as long as you collaborate and set the family and the child first. And when we do intervention, it's important to have goals. In the first place, short-term goals. So during each intervention, you discuss and you listen to the parents what they would like their child to achieve in the next small period. But we also have long-term goals. And our long-term goal is the optimization of the participation of child and family. And very often, families and health professionals focus on the walking ability. But, and here I would like to share some personal experience, because in the children with rather restricted mobility, perhaps aiming for walking is not the best goal. So my personal experience is the following. You can see I sit in a wheelchair, and that is because at the age of 16 years, I had a sports accident. I broke my back, and this resulted in a partial spinal cord lesion. And the doctors thought that it was not very likely that I would be able to walk again. And then, after having spent almost a year horizontally, I was allowed to practice again. And being a bit on the hyperactive side of the spectrum, I practiced like an idiot. And there, I've been walking again. I've been walking for over 25 years. But in the end, my walking and standing capacities deteriorated. And I realized how much energy it costed. It really took all my cerebral activity. I could no longer communicate. I could no longer think properly because all the energy went into standing and walking. So I decided myself, now it's time to start to use the wheelchair. And when I got a wheelchair, the people further around really pitied me. But I was so happy. You can't imagine how happy I was, because I got my brain back. I could talk, communicate, and think again. So I really think that we should take it into mind when we are dealing with children who have rather restricted mobility, that perhaps our ultimate goal should not be walking independently. So now we go to what do we know about the evidence that early intervention is effective. And there I would like to distinguish two groups. Groups of infants that I would call infants at moderate to high risk. On the slide I call them moderate risk. And children at very high risk. So first, the children at moderate risk. And we are talking about especially about preterm infants and infants with low birth weight. That is, infants without a major lesion of the brain. And this is the majority of infants born preterm. And for these infants, we have ample evidence. And the first thing that we learned is that parental support, especially support of parent-infant interaction, is really beneficial both for parent well-being and infant development. Next, we also know that so-called developmental programs, that are programs where families learn how they can stimulate at home their infant's development. that those programs have a positive effect on the infant's cognitive development, both in infancy and preschool age. We don't know whether the effect is also present at school age. Too few studies. We also know that the same type of programs also have a positive effect on motor development, but the effect is smaller than the effect on cognitive development, and it only is present in infancy. Last but not least, there's no evidence that programs such as NDT, Neurodevelopmental Treatment or BOBAT, or treatment according to VOITA are effective. And a little bit more on that. So we really have quite a number of studies on the effects of neurodevelopmental treatment. And the systematic reviews around really conclude all that there's no beneficial effect of NDT on infant development in those infants at moderate risk. There's even one study that indicated that hands-on techniques are associated with a less favorable infant motor outcome. And what do we know about treatment according to VOITA? VOITA is around for more than 50 years, and over the time, only 3 studies in infants have been performed, 2 of them having a very weak methodological quality. So there's only 1 RCT left, and that was a small study on infants with postural asymmetry that compared 8 weeks of NDT with 8 weeks of VOITA, and that study showed that the VOITA infants were a bit less asymmetric after the 8 weeks than the infants that received NDT, but whether infant development overall was affected was not reported. So the conclusion really is currently, over 50 years, we don't have evidence that VOITA is associated with a positive effect on infant development. I also would like to tell a little bit about COPCA. COPCA is the program that we developed in Groningen. It means coping with and caring for infants with special needs. It was developed by Tineke Dirks and me, and further developed by Shirin Nakwari-Ziegler. And COPCA has 2 components. And really the very first component is the family. And keywords in COPCA are family autonomy, coaching, and optimizing participation. The second component is the child and child development, and there we use the principles of the neuronal group selection theory, and keywords there are exploration, variation, challenging the child to self-produce its own activity, play, and fun. And so we have 1 RCT carried out in the infants at moderate risk, and if you would like to see the details, go Saturday to the poster of Shirin. And here you see the outcome parameter that we used here is the infant motor profile movement variation score. And we used 6 months of intervention, so at T1, that was the start. T2 was after 6 months of intervention. The red line are the COPCA infants, and the blue line are the control group, and the control group we labeled TIP. TIP means typical infant physiotherapy. And this was a study in Switzerland, so it's the mixed bag of what physios do in Switzerland. So you see both groups, the scores improve. But now the interesting thing is that after the intervention stopped, you see that the score still improves in the COPCA group, while it doesn't in the control group. And we think that this prolonged effect is due to the fact that the families understood by means of the COPCA intervention how they, in their own way, in their own life, can stimulate the infant's development. And now we move to the second group, the infants at very high risk. And we are talking about infants who have a serious brain lesion or present with clearly atypical general movements at 3 months corrected age. Here, and that's sad, we have much less evidence, and the studies performed are relatively small. Nevertheless, over the last 5 years, we really have more evidence, and we have evidence that the following components are effective to improve the infant's motor and cognitive development. In the first place, that we children allow to discover all by themselves their environment and discover all by themselves how they can move and find their own solutions. So it's about self-produced movements, trial and error. The brain loves errors. It learns from errors. And the other thing that we agree upon in the literature is that we need to set goals, and that the goals should be challenging but achievable. What is debated in the literature is how we should deal with the parents, whether we should use parent training, instruct them, or coach them. And then the difficult thing is that on the word coaching, there's an enormous confusion in the literature, which makes communication not easier. If you would like to know more about this coaching debate, please visit the symposium that starts after this lecture. What we also do not know, and is debated, whether the hands-on techniques of neurodevelopmental treatment may contribute in this group, the group of very high-risk infants. And I could imagine that a little bit of postural support, hands-on, could be beneficial. I don't think that the facilitation of a total movement trajectory with your hands, that would help the children. But we don't know. And to give us a little bit an idea, what are the programs available and what were their results? We have the Australian GAME method, which means goal-oriented, activity-based motor training with environmental enrichment. Interestingly, this approach includes a little bit of hands-on techniques, just the amount that I explained. 2 RCTs have been carried out on GAME, and GAME was compared to the Australian variant of TIP, typical infant physiotherapy. And both studies concluded that GAME was associated with a better motor development and that there was no effect on maternal well-being. But, this is the but I have, we don't know whether the effect of the studies is due to the contents of the program or whether it was the intensity, because you see in both studies GAME was practiced much more than in the TIP group. And we very well know that more practice is better, so we don't know. Then we have the Small Step program from Sweden, which is a program of which the content really is more or less similar to the GAME program. Here we had 1 RCT with children with serious brain lesion or neurological deviancy. And here 9 months of intervention was, the Small Steps program was compared to standard care. And you see outcome, motor and cognitive and maternal well-being, it was similar in both groups. And the study said there was an indication that the most severely affected infants profited most of the Small Steps program. Then we have baby-constrained induced movement therapy. What do we know? We use it in infants with or at high risk of unilateral spastic CP. The first study was a retrospective study, and it found that baby-constrained induced movement therapy was associated with a better hand function in those children, better than in the Swedish TIP group. But a retrospective study is not the ultimate evidence, so a prospective RCT followed. And there they found that outcome in the two groups, constraint-induced movement therapy and the Swedish TIP, was similar. But if they focused their analysis on the children who were diagnosed with unilateral CP, they found that constraint-induced movement therapy resulted in a better outcome in hand function than the TIP group. And then the third study we have compared constraint-induced movement therapy with intensive bimanual therapy. And that study concluded that both interventions are equally effective to promote hand function. And then I also would like to mention the effect of COPCA in the very high-risk infants. And we carried out 2 trials. The first one, we compared COPCA with the Dutch variant of TIP, and we had children with atypical general movements at 3 months. And you can see that motor outcome in both groups at 18 months was similar, and cognitive outcome, we found that the COPCA group did a little bit better than the TIP group, where cognition remained the same. The second study in children with serious brain lesions, 12 months of randomized intervention, we found that motor and cognitive outcome in both groups was similar. And we also found that in the COPCA group, parental well-being improved over time, and that was not the case in the TIP group. And now you may think, oh, all those studies, they actually more or less find that outcome in both interventions is similar. So it doesn't matter actually what you do. And I don't think that is the right conclusion, because the studies use the RCT design, because that's the best design. But you have to realize that the RCT design has been developed to study the effect of drugs, where you have clear groups, the drug and a neutral placebo. But when you compare 2 types of intervention, you actually compare 2 mixed bags of behavior. And you can be certain that the contents of the bags overlaps and therewith obscuring the differences in outcome. So we realized this in Groningen, and so from the very onset in all our 3 RCTs, we carried out a so-called process analysis, which means that we filmed in all participating infants at least twice what happened during the intervention. So we had hundreds of videos of half an hour or a whole hour, and we quantified that. So 1 sentence, years of work, but nevertheless, it taught us a lot. And so in the studies, we found that the better motor outcome was associated with more time spent during the intervention with coaching. And we also found that more time spent with being challenged as a child to act yourself was associated with a better motor outcome. We also found that more time spent during intervention with passive motor experience was associated with less favorable motor outcome. And in the children who were not diagnosed with CP, we found that more time spent with hands-on techniques was also associated with less favorable motor outcome. And then, last but not least, we also found that more time spent with coaching was associated with a better family empowerment. And so, if we sum up what I tried to tell you, that we have to distinguish two groups, the infants at moderate risk and the infants at very high risk. In the first group, we have ample evidence, and we know that parental support, in particular coaching, and the child being challenged to produce self-its movements with trial and error are associated with a better outcome. We also know that there's no evidence whatsoever that NDT is helpful in these children. With the infant being challenged to move all by itself, we know, and that is really something to think of, that more practice is better, so higher dosages is better. But now comes the difficulty. If we communicate this to families, we get a problem, because it may mean that families start to think, I have to practice with my child all day, and life turns into all-day therapy. And that is not participation. And also, if you focus on more is better, parents may soon start to feel guilty, because when is enough? So I think it's really the skill of the professional to discuss with the parents what is achievable, feasible, what is nice for daily participation and child development. Then the second group, I told you, less evidence, but we know that the same two components that are positive in the infants at moderate risk also are positive in the very high-risk infants. The effect of NDT in this group, we don't know. And what we also don't know, and that is really a pity, what the effect is of environmental modifications. And really, we need more research here to know what the effects of assistive devices are. Anyway, I would like to suggest that when children at early age show signs of that their activities are really limited, do not hesitate to discuss with parents the use of assistive devices. You can see I'm a fan of assistive devices, and like the word tells you, they are there to assist you. Bernard mentioned already the book, so if you would like to know more about early intervention, but also would you like to know more how you can detect the infants at high risk, go and read the books. And for families and users, the take-home messages. What did we learn? We know that the family should be central. Keywords here are autonomy, goal setting, participation, and coaching. We know with ample evidence that developmental stimulation is effective, challenging the child to produce all by itself the movements with trial and error. Voita treatment, there's no evidence whatsoever on its effectiveness. NDT, there we know that infants at moderate risk, it is not effective. And in infants at very high risk, it is unclear what the effect might be. And last but not least, do not hesitate to start with, at early age, with the assistive devices. Thank you very much for your attention.
Thank you very much, Mijna, for sharing your experience and your perspective. I think we've learned a lot. So I've certainly written here, life is more than therapy. I suspected that, but now I know. And then I think we all here recall for all those involved in looking after children to show one another what they do, to dispel some of the misunderstandings there can be. And I mean all those who use names for what they do, or what Mijna called with some irony, typical therapy. And then I'm sure that we are convinced now that coaching is really key, and your team has really led the way. And there'll be questions now, and I'm sure there'll be a question on coping, because coping it was not set as one of the explicit goals of coaching, which, as you underlined, was not training. And if nobody else asks this question, I will.
Yes.
Mijna, take us through coping.
Yeah, so yes, what does it mean to cope? It was, I think, on one of the first slides, that one of the essential things in early intervention is that the family learns to cope with this ever-changing situation of having a child with special needs. And first, to deal with all the uncertainties that surround this situation, and later on, you have the realization of that this child is a little bit different than most children, and how you can function, how you can live your own life with having such a child in your family. So I think coping with the situation is quite essential.
So coping is a personal understanding of the present, but also projection in the future. You started with sharing your own experience.
Yeah.
Do you have advice for us?
Yeah, so now the family is really central. So I think the role of a coach is really to listen and to observe. So listen to what the family thinks that are the most important problems. And so the listening and the observation of how the child behaves and how the family interacts with the child. So that are all important ingredients of the coaching. Yeah? So it's really a continuous interaction and a dialogue, actually.
Thank you, Mijna. Any other questions?
Can I raise a question?
Sure.
You said that life is more than therapy, of course. You said maybe walking is not the goal. I wonder whether there are, I know that there are some critical periods in development, but is there some critical period for listening? I mean, when are you able to listen the therapist saying that walking is not the goal, when as a parent, considering that your child will not walk is just not thinkable when he's very, very young. And in fact, you start learning that you need time to get these ideas in you, and you get to learn this because life is more important than therapy. So you need more time for life, so you are less dedicated to therapy. So are there periods where parents can listen what you think is important?
Thank you. I think this is an important question. And I think it's really family specific and child specific. So I think that's one of the essential things of coaching, that you indeed listen to how far the parents are, what they can cope with for information, and you see what the infant is doing. And so if parents say in a 3 months old of whom you think, I'm not so sure whether this child will be able to walk, and the parents say, our goal is that the infant will be walking later on, then you can say, just depending on the family, but you can communicate that this is far ahead and that we focus now on the present. I think we often have too much the long-term goals in focus, and I think life is about living in the present especially, not only in the future. So I would say discuss it with the parents and leave it just in the middle, whether walking ability will be an achievable goal. And when the parents gradually understand, because the infant tells them actually what are the possibilities, then you gradually get to the assistive devices, I think. And I must say, but that's of course my own situation, I have no problem whatsoever to communicate that life is more than walking.
Mijna, you also said that it's difficult to apply the methodology of randomized controlled trials in our field because you're trying to compare bags of complexity, as you said. You've done a lot of research. Do you see existing methodologies that can help us better? Or can you tell us where we should look further?
Yeah, I've been thinking about this a lot, of course. What is the optimal design for studies in early intervention? So I think the RCTs are not bad, but then you should combine them indeed with this process evaluation so that you can look into the black box. So what are people doing? And the alternative design, I think, would be that you follow the children and do A-B design. So because the group of children we are dealing with are very heterogeneous, and so that makes comparison difficult. But of course, if you deal with infant development, when you have intervention A at early age and then 3 months later, intervention B at a little bit later age, that's also complicated. So we have other confounders there.
There is a question over there.
Have you compared between game program and small step program? And if not, why not?
So if I understood correctly, you asked about the small step program? But what? I couldn't hear that, sorry.
Compare the game program and the small step program between us.
Oh, yeah. No, that has not been studied, whether the effect of the game program in this group is different from the small step program. And you have to realize that collecting these groups of infants at very high risk takes a lot of time. The study, for instance, we performed on COPCA in the infants with serious brain lesions. It took us 5 years with an inclusion area covering the half of the Netherlands to get a group of a little bit more than 40 children. So these studies are not easy. And so one could think then we need multi-center trials. That could be an option, but then again, it's not easy because then you need to program it such that people do the same things. Yeah. Yeah.
And it's exactly in this spirit that La Fondation Paralysie Cérébrale has been sponsoring big projects. And there's a big project now starting with many European countries involved. Some people I recognize here in the room, aiming at defining what is really relevant, what is most salient in children with high risk of developing adverse outcomes, including cerebral palsy. Mijna, thank you very much, and thank you for this invitation, which I repeat, and I hope we can organize it within the EACD, of sharing practices, going beyond the puns of the acronyms, and spelling out what we think we're doing, learn from one another for the benefit of children who will become adults, and as children and adults will participate in society. Thank you very much.
Thank you.